Welcome to the Seasoned Sonographer, the podcast where experience meets education in the world of OBGYN ultrasound. My name is Lynn Flamm, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OBGYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Welcome back to the Seasoned Sonographer. I'm your host, Lynn Flamm, registered diagnostic medical sonographer, and today we're diving into one of the most fascinating areas of prenatal imaging, the fetal heart. Fetal echocardiography allows us to look deep into cardiac structures and function before a baby is born, and that early insight can completely change how we plan care. Joining me today is Dr. Caroline Lee, a pediatric cardiologist who specializes in diagnosing and managing congenital heart disease from the womb through childhood. She's here to help us understand the foundations of fetal echo, what we're actually looking for, and how we use color and Doppler, and what differentiates a normal from abnormal exam. So whether you're a student sonographer, a seasoned tech, or an OB provider curious about what goes into these detailed heart scans, this episode will give you a clear and confident understanding of fetal echocardiography basics. Welcome, Dr. Lee, to the Seasoned Sonographer.
Thanks, Lynn. Very happy to be here.
All right, let's get started. Dr. Lee, can you start by explaining what a fetal echocardiogram is and how it differs from the basic heart screening done on a routine anatomy screen?
A fetal echocardiogram is a specialized ultrasound that focuses on the heart, and we look at the heart from multiple views, multiple vantage points, and look at the heart structures from different angles to confirm normal anatomy or to diagnose heart defects. We look at the heart rhythm, we look at the heart rate, and we look at the blood flow patterns throughout the heart. How is it different from the basic heart screening done during a routine anatomy scan? Well, a routine anatomy scan should include the 4-chamber view, the left ventricular and right ventricular outflow tracts, and the 3-vessel view as well, right? And then the 3-vessel trachea view if feasible. We do all of those views, but we also add a lot more in terms of sagittal plane views, looking at the aortic arch and ductal arch, the vena cavae from these views, the atrial septum from the sagittal view, which is perpendicular to the 4-chamber view, and we use a lot of color and spectral Doppler, as well as M-mode.
At what gestational age do you typically prefer to perform the fetal echo?
So normally, because the routine anatomic survey is done between 18 or 20, 22 weeks or so, we will usually get referrals after that. So we don't usually get referrals before 18 weeks, although now there is a lot more interest in early ultrasound screening. So we will start probably to see earlier referrals and do earlier fetal ultrasounds. So I think the perfect window in terms of nice images and clarity is around 24 weeks or so, but honestly, that could be considered relatively delayed in getting a good understanding of the heart, especially when there's a suspected heart defect, because that will limit the family's options for the pregnancy if something abnormal is found. So we try and get families in before 22 weeks if possible.
Right, so as soon as possible to have more options. What are some of the main indications that they refer patients to you for a fetal echo?
So there are a lot of different indications that warrant a fetal echo. Increased nuchal translucency, so that's seen earlier in gestation, and typically the threshold is greater than 3.5 millimeters. Now that routine non-invasive prenatal testing is performed in so many pregnancies, if that is positive for trisomy 13, 18, or 21, those trisomies often have an associated heart defect. So that might be a reason. Family history of a congenital heart defect, specifically in first-degree relatives, so the mother, the father, the sibling of the fetus. Now, in vitro fertilization is also becoming a more common indication. In fact, at our heart center, that has become one of the top referral reasons for screening fetal echocardiogram. Certainly, if there's a suspected cardiac abnormality, you've done the routine anatomic survey, and the sonographer and provider are concerned about a heart defect, that would obviously be a reason. And that's our highest yield, is when the local provider suspects a problem. That is the highest yield to find a heart defect. Much more common to find a problem there than for the screening echoes, such as IVF or family history. Maternal pre-existing diabetes, lupus or Sjogren's syndrome that can be associated with the development of complete heart block. If there are any concerns about the baby's heart rhythm or rate, whether it's too fast or too slow, if the heart size is too big. Monochorionic twinning is another important indication for fetal echo due to the increased risk of a heart defect in one or both fetuses, and also the risk of twin-to-twin transfusion syndrome, which can have cardiac manifestations.
That's a long list.
It's a long list.
So for sonographers learning fetal echo or trying to learn some of those extra views, understanding fetal circulation is so important. Can you walk us through briefly kind of how blood flows through the fetal heart and why it's so different from postnatal circulation? I'm talking about like the ductus arteriosus and the foramen ovale and how those close after birth. But can you kind of walk us through the blood flow?
Yes, I think the fetal circulation is simply a wonder and really beautiful. And as people who do ultrasound, I think to get a view into the circulation of a developing fetus is pretty amazing. So if we start with the placenta, and we talk about that cord, the umbilical cord has typically 3 vessels, 1 umbilical vein and 2 umbilical arteries. Now, I had to learn this, and really it was sort of against my intuition, but the umbilical vein, you usually think of vein as blue or deoxygenated blood, but actually in the fetal circulation, the umbilical vein is the most highly oxygenated blood. It's coming out of the placenta, going to the fetus. So that if we follow that umbilical vein, that's the highest concentration of oxygen in the fetal circulation. So the reddest blood that goes in through to the umbilical cord, into the baby's abdomen, through the liver, and it encounters the first shunt, which is called the ductus venosus. It is considered a sphincter. It's where blood accelerates through this ductus venosus to propel it towards the inferior vena cava into the right atrium. Now, this reddest blood is going to go from the right atrium across our second shunt, the foramen ovale, into the left atrium. So now we have the baby's highest oxygenated blood going into the left atrium, into the left ventricle, out the aorta, and this is where that reddest blood goes to the coronary arteries, so to supply oxygen to the heart itself, and to the fetal brain, so the ascending aorta, and to the 3 head and neck vessels that come off of the aortic arch. Now, meanwhile, and this is what's so amazing about the fetal circulation, meanwhile, you have blood coming from the superior vena cava, so that's relatively low oxygenated blood coming into the right atrium, and it's crisscrossing in that right atrium. There are 2 flow patterns going on in that right atrium. We just talked about the one coming from the umbilical vein through the ductus venosus, through the IVC, across the atrial septum. But you also have this blue blood from the superior vena cava coming south into the right atrium and going into the right ventricle. So these 2 streams of blood flow are crisscrossing there in the right atrium. And then that blue blood goes to the right ventricle, out the pulmonary artery. And then at the pulmonary artery, it has 3 choices. It's kind of like a 3-way intersection where it can go to the right lung or the left lung, but the majority of that blood flow goes to the ductus arteriosus. So that's our 3rd and final shunt. The ductus arteriosus connects the pulmonary artery to the descending aorta. And so the majority of blood from the right ventricle goes across the ductus arteriosus down to the descending aorta. And that descending aorta will supply blood to the fetus's lower body and send blood back via usually 2 umbilical arteries back to the placenta, and that circulation starts again. So those are three shunts, ductus venosus, foramen ovale, and ductus arteriosus, that are important in the fetal circulation that we don't need after birth. That should go away, close up after birth. But those are how the fetus is able to grow and develop in utero.
Wow, what a course the blood flow takes. And then in our OB office, we check that umbilical artery Doppler, the deoxygenated blood going back to the placenta. We check that for any placental resistance, and in those fetal growth restricted babies, and monitor that too. So it's just amazing, isn't it?
Yeah, and I think that's a good point about the fetal echo. And what I think is so amazing to be able to document is not only just the flow patterns using color Doppler, but using your pulse or spectral Doppler to document the type, the direction of blood flow, but also sort of the back and forth to determine if there is resistance problems with reversal of your A wave or absent diastolic flow in the umbilical artery. So I think, yes, the use of Doppler in ultrasound is just another way to understand the baby's physiology.
And when you're using the color Doppler, how does that knowledge of fetal flow direction guide your interpretation? Sometimes when I put the color Doppler on, it looks like a mess. And so it's kind of hard to interpret sometimes. How does that guide your interpretation? Do you use color flow all the time, or do you use just the grayscale?
Color flow all the time on
Okay.
every valve. Tricuspid valve, looking for inflow and regurgitation. Out the pulmonary valve to look for signs of like flow acceleration, so aliasing to suggest there's stenosis, and then looking for regurgitation. But it is true, there's a lot going on in that very little heart. And when you put color, I mean narrowing your sector width to really focus on the vessel or valve of interest. But looking at the direction, red versus blue flow, is really essential to interpreting a fetal echocardiogram. So we use it all the time in every view.
So let's go through the main views we obtain in a standard fetal heart exam, starting with the four chamber. What are the key landmarks and findings that tell you the anatomy of that four chamber heart is normal?
The four chamber view is always my favorite as a cardiology fellow, looking at the heart, because it seems sort of most intuitive in terms of the structures. So we look at, first of all, the axis of the heart. So what that means is this is in a transverse plane. So we look at where the spine is, and we draw a line from the spine straight up to the anterior chest wall. So right down the midline. And then we draw a line along where the ventricular septum is. And that angle where those two lines meet should be about 45 degrees to the left, with the apex of the heart pointing to the left. And so that is a normal axis. And actually, I think this is one of the quote pro tips about for sonographers looking at the heart, is really to tune your eyes to the axis, because it should be 45 degrees to the midline, plus or minus 20 degrees. If you notice that that apex is flipped more leftward, so now you're more at like 90 degrees from midline, so the apex of the heart is pointing to the baby's left side, that is a clue that could be a conotruncal heart defect. Conotruncal meaning outflow tracts. So that includes transposition of the great arteries, tetralogy of Fallot, truncus arteriosus. So that, I think, is a really good clue. So train your eye to look at the axis. And then you look at the relative size of the chambers to each other. So the right atrium versus the left atrium should be about the same size. Same with the ventricles, right ventricle to the left ventricle, and pulmonary artery to the aorta when you do your outflow tract sweeps. In that four chamber view, the right sided chambers are allowed to be a little bit bigger than the left, because in the fetal circulation, the right heart carries a little bit more cardiac output than the left side. We look for the offset of the atrioventricular valves. So the AV valves are the tricuspid and mitral valve. The tricuspid valve should sit slightly inferior to the insertion point of the mitral valve. So if you look at the crux of the heart, so the middle of the heart, the tricuspid valve insertion point on the septum should sit slightly lower than the mitral valve. If they are at the same level, then you should be thinking about an AV canal type of defect or an endocardial cushion defect, such as a complete AV canal. In the right ventricle, so to determine that it is the right ventricle, we, in addition to the tricuspid valve offset being slightly inferior, we look for a moderator band, so muscle towards the apex of the right ventricle, whereas the left ventricle be smooth-walled. And the extra little tip to recognize the right ventricle and the tricuspid valve, because the AV valve always goes with the ventricle. So a tricuspid valve always enters into a right ventricle, and the mitral valve always enters into the left ventricle. So in addition to the offset of the AV valves, the tricuspid valve also has chordal attachments to the ventricular septum. The tricuspid valve is septophilic, meaning it has attachment to the ventricular septum, whereas the mitral valve leaflets do not have cords attached to the septum. It's septophobic. So that's another kind of clue to help confirm that you've got the normal valves and ventricles on the correct side. Another thing I'll say about the 4-chamber view to train your eye to, because one of the most commonly missed heart defects is total anomalous pulmonary venous return, meaning the pulmonary veins do not return to the left atrium normally. They return to a confluence behind the left atrium, so a chamber behind the left atrium. So if you train your eye, even if you're not using color, if you're just using 2D and you're looking at your 4-chamber view, you should be looking that the left atrium has 2 pulmonary veins coming into them. So one from the right upper and one from the left lower. You'll see that. And you contrast that to the right atrium contour, which I call looks bald. There's nothing, it's just smooth and there's nothing going into it. So then, because TAPVR or TAPVC, total anomalous pulmonary venous return or connection, is easily missed. And one way to hopefully avoid that is to look for those pulmonary veins by 2D in that 4-chamber view.
And I think that they're trying to get those pulmonary veins, that view, incorporated into the standard heart views. And so I know that I have started documenting those pulmonary veins going into that left atrium on all my heart views, just getting ready for the standard to change.
Along with that, can I just mention another clue to picking that diagnosis up is that when you look at in that 4-chamber view, you have your left atrium, and it should be, I call them besties, with the descending aorta circle. That's right behind there, right in front of the spine is the descending aorta, and it's besties with the left atrium. Nothing should come between them. So if you see an increased space between the left atrial wall and that descending aorta circle, and it can be very subtle, there can be an extra small chamber in between them. And so really looking at the proximity of left atrium and aorta.
And then how about the left ventricular outflow tract and right ventricular outflow tract? I know when I look at the left ventricular outflow tract, I can see it coming from the left ventricle, and I look for that smooth contour of the ventricular septum coming out for that view. What else are we looking for? Is that
I think that's a really important view. So the most common heart defect is the ventricular septal defect, the VSD, and perimembranous VSD is very common type. There's muscular type and perimembranous and some other types, but those are the 2 most common. The perimembranous septum is that part of the ventricular septum between the aortic valve and the tricuspid valve. So if you are going from a 4-chamber view where you can see the tricuspid valve and you're scanning to the anterior, from there to the first outflow tract, which should arise from your left ventricle, you'll get your aortic valve. And that little space between tricuspid and aortic valve is your perimembranous area. It's right smack dab in the middle of the heart. And this is why it's easy to miss. And I certainly have missed perimembranous VSDs, and even when they are not small, because there's a lot of action going in the middle of the heart with different flows in and out, in through the tricuspid valve and mitral valves, out through the aorta. But a clue there is when you're looking at the left ventricular outflow tract, you're doing that sweep from four-chamber to your left ventricular outflow tract. Yes, you should be looking for a smooth line of the ventricular septum extending to the aortic outflow tract. You want to see a clean white line there of ventricular septum smoothly transitioning to the LV outflow tract. If you see a break or you can't make it connect, then you should be suspicious of a perimembranous VSD. In addition, you should look at the valve leaflets to make sure they're thin and that they're not clunky, chunky, and that they open wide.
And then the right ventricular outflow tract, I think there's some discrepancy between sonographers on what is that view. The outflow tract should cross, and you can see that right ventricular outflow tract cross. Sometimes that is the view, and then other times it's more of like a short axis view with that pulmonary artery coming across and over the top of the aorta, going into that ductal arch. What is the correct right ventricular outflow tract view that you're looking for? And then when that arch over splits and into the right and left, is that what you're looking for, or is it mainly just the crossing?
So it is just, so all of this is done in a transverse plane. What we're talking about, the screening views where we've got the babies in a cross section, right? So a transverse plane, you got a four-chamber view, you move ever so slightly anteriorly, the baby's anterior, and to get the LV outflow tract, and then just slightly a little bit more to get the right ventricular outflow tract. So you're really not moving around to get those. You're just kind of in the same, your probe is pretty much in the same place, and just slight little movements to show the outflow tracts. Now, you may have to adjust a little bit to get your best views, but you're not going from four-chamber view and then you're going to swing around somewhere else to get the outflow tract views. It really should be in that similar spot, but just a different plane. And so once you get your LV outflow tract, you just come swing a little bit more anteriorly, and then you will get the right ventricular outflow tract, and that should cross. And really, you're just looking for, number one, that it crosses the aortic outflow tract. Number two, that the pulmonary valve leaflets, again, are thin and very mobile, that you can barely see them to rule out pulmonary stenosis. What you're describing with the short axis view is something we mainly see kind of closer to a more sagittal plane. So like almost 90 degrees to the four-chamber view. So that is a different way of looking at the pulmonary outflow tract. So I really think either way, but the true sort of documenting crossing of outflow tracts comes in that more transverse plane.
Okay. And then the three vessel trachea view is sometimes challenging for new sonographers. And the three vessel trachea view and that three vessel view are fairly new views for the 76805 standard second trimester ultrasound. Can you describe what a normal three vessel trachea view looks like and what can be off when pathology is present, or what would an abnormal look like when the pathology is present?
Yes, I love these views, the three vessel view and three vessel trachea view. And I think if you can understand it and master it, you will feel powerful. I really think between four-chamber and outflow tracts, that's kind of like what you're supposed to do and everyone should be able to do. But if you can really understand and get good at the three vessel and three vessel trachea view, you are really going to pick up the majority of heart defects. So the location of this plane is more cephalad than our outflow tracts, right? So we're going a little bit north towards the baby's head in the baby's mediastinum. So we're looking at the three vessels, and they are, and I'm going to say these from right to left. Those vessels are a superior vena cava, a right superior vena cava, aorta, and pulmonary artery. Right to left, and that is also posterior to anterior. SVC is most posterior, aorta in the middle, and the pulmonary artery is more anterior. So you have this oblique line, kind of a diagonal, connect the dots of three vessels there. And then you should look at the relative sizes. So it should be small, medium, large. The SVC is the smallest of the three, the aorta a little bigger, and the pulmonary artery is the largest of the three. So if there are only two vessels, for example, then you should be concerned that an outflow tract is missing, like pulmonary atresia, for example. On the other hand, if there's an extra vessel, a fourth vessel, it's typically on the left side, so to the left of the pulmonary artery, that can indicate there's also a left superior vena cava. So you can have bilateral SVC, one on the right and one on the left, and that is a benign finding, by the way, usually. But that leftward vessel, that extra fourth vessel on the left, could also be an abnormal vein, as seen in total anomalous pulmonary venous return, where that vessel is how the pulmonary veins end up entering into the superior vena cava. Really, I don't think you have to know all the details of your differential necessarily, like I'm telling you what I'm thinking of when I see them. You just really have to really look for three vessels in an oblique line from right to left, from posterior to anterior, and from small to medium to large. And if anything is awry in that, for example, if the aorta looks about the same size as the SVC, then that would make you think, gosh, is that aortic arch kind of small? Could this be something like a coarctation of the aorta? Very difficult to diagnose, but one of the clues is having a relatively small aorta in that view.
And then when I look at the three vessel trachea view, I always think kind of along those same lines, only I think I'm looking for that V shape where the pulmonary artery and aorta come and meet and make that V shape. And then the trachea is to the right of that V. And I mean, as a standard ultrasound tech and not a fetal echo tech, is that correct thinking?
Yes. So the three vessel trachea view, what we're trying to accomplish there, because our three vessel view is to really confirm those three vessels are there in that order and those sizes. The point of the three vessel trachea view is to compare the sizes of the ductal arch and aortic arch and to confirm we have a left aortic arch, which is normal. So how do we do that? Well, it is just a little bit more cephalad than the three vessel view as well. But what we're going to do is follow the aortic circle is going to become the transverse arch, and the pulmonary artery circle is going to become the ductal arch. And those two arches are what make what we call the V. They are going to converge together to the descending aorta circle by the spine. So that's what you're looking for. And my sonographers I work with I'm always saying, did you show the V? Do you see the V? We're looking for that V where we have both parts of the V are nice and similar in size. So again, if I see a difference in the size of those two arches, specifically the aortic arch appearing smaller, then I am concerned about aortic arch hypoplasia and possible coarctation. So that's abnormal. They should be roughly about the same size. We want a nice juicy aortic arch about the same size as the ductal arch, and they converge together to the V, and they meet at the descending aorta circle by the spine. That V is going to occur to the left of the trachea, and that's what defines a left aortic arch, when that transverse aorta, which is part of that V, is to the left of the trachea. It takes a little bit of getting used to identify the trachea. At first, you may think it's like an extra vessel because it's round-ish and it's fluid-filled, and so it looks like maybe another vessel, but it will not have color flow. When you put your color Doppler on there, there's no flow through it, so you won't see that. But you'll get used to seeing this little subtle circle there to the right of the V. Or another way of saying it, the V is to the left of that circle. So this is because more people are using this three vessel trachea view, we've seen a lot more diagnoses prenatally of vascular rings. A vascular ring is when blood vessels encircle the esophagus and trachea. You can diagnose a vascular ring in the three vessel trachea view. Your first clue will be that you have a right aortic arch. So when you're going from the three vessel to the three vessel trachea view, your aortic arch will go to the right of the trachea. And so you won't get that V because the aorta is going in the other direction. So if you see a right aortic arch, you don't have to get fancy and figure out what kind of vascular ring it is because there are different types. If you see a right aortic arch, you should send them for a fetal echo. That is pretty much by definition going to be a vascular ring.
So the additional views like the aortic arch and the ductal arch and bicaval views, what information do those add? Because those are optional views that are not traditionally performed in the standard scan, but in a fetal echo. Right.
Yes. So honestly, in a standard scan, I don't really think they're critical. If you get really good 4-chamber outflow tract, 3-vessel and 3-vessel trachea views, really that is the meat of, you've got so much information there. The ductal and aortic arch views, I think you could really, you could practice it and they're pretty to get, but that's, I think, the purview of the fetal echocardiogram where we look at that. So those are best seen. So we can see, as I just mentioned, the aortic arch and ductal arch in that 3-vessel trachea view. Those are what make the V, are those two arches. But you can see it better laid out on a sagittal view. So we're now 90 degrees orthogonal to where we just were, to see the classic candy cane view of the aortic arch, or candy cane appearance of the aortic arch, and the classic hockey stick appearance of the ductal arch. And why do they look that way? Well, the aortic arch is going to arise from the mid-thorax, whereas the duct, because it's coming off of the aorta, and that aortic valve, if you think about, if you know what a short axis looks like, that aortic valve is in the middle of the short axis. It's like that aortic valve sits in the middle of all the action. So the aortic arch is going to arise from the middle of the thorax and make a more sharp candy cane type of turn. The aortic arch can be recognized because it has head and neck vessels arising from them, typically 3. So if you see that, and if you put color Doppler on and you see flow in those head and neck vessels, that confirms you have an aortic arch. Whereas the ductal arch, since it's arising from the pulmonary artery, and the pulmonary artery is the most anterior structure of the heart, it's going to come from right behind the sternum. And so that makes a more elongated course to meet the descending aorta, and hence the more flattened appearance of that arch. And the ductal arch will not have any vessels arising from it. And so the sagittal view is really nice for seeing the origin of those arches and the relative contours of them. But to diagnose where they converge, like the V, the convergence of the V where we did in the 3-vessel trachea view, it's much easier to appreciate them distinct from one another in that 3-vessel trachea view, because when the ductal arch and aortic arch converge together in the sagittal plane views, they just sort of run together and it can be hard to distinguish. But it's important to remember the ductal arch sits inferior to the aortic arch.
When you add color Doppler to all this, what flow patterns are most important to confirm? Is it basically just, it's not basic at all. Is it mainly just to check the flow patterns and make sure all the blood is going in the proper direction?
All of that. As I started out by saying, we put really color Doppler on every aspect of the heart. So we can start with, say, the 4-chamber view and document inflow through the tricuspid valve and mitral valve and ensure there's no regurgitation of either. Now, a little bit of TR, a very minimal amount, is okay and normal in the fetus, but we really shouldn't see more than very mild amount, nor should we see mitral regurgitation. So color Doppler is important there. Color Doppler on the ventricular septum to look for a ventricular septal defect. Color flow Doppler across the outflow tracts to document that there is sort of laminar color flow. Now, we do adjust our color scale or our Nyquist limit depending on what we're looking at, because vessels or outflow tracts have a higher velocity flow through them. So our Nyquist limit will go, our color scale will go higher. Whereas if we're looking to document vena cava flow or pulmonary vein flows, because they're veins, their velocities are lower, we're going to turn our color scale down for those. So yes, we confirm pulmonary venous return. We want to document at least one pulmonary vein from each side. So one right vein and one left vein entering into the left atrium. We want to confirm that the SVC and IVC flow in the bicaval view, which is also in that sagittal plane, we want to confirm that that is normal as well. And then the ductus arteriosus is another important place to look at color flow. Ductal constriction is not often seen, but if it is present, can really affect the heart function and the development of ventricular hypertrophy and pulmonary hypertension after a baby's born. So we want to put color flow on the ductus arteriosus to ensure that we don't see signs of ductal constriction. But in addition to color, we would also do spectral Doppler on all of those same structures as well.
That's a lot. Recently I did a Fetal Heart boot camp, and now I have started putting my power Doppler on the 3-vessel trachea view to make sure the blood flows in the same direction from the pulmonary artery and the aorta as they come together. That should be the same color with blood flow flowing in the same direction.
That's a really good point about that V vessel. So yes, we would put color as every view, we put color Doppler. So in that 3-vessel trachea view, we want to see that the two arches are going towards that descending aorta circle. So if you say have severe pulmonary stenosis or pulmonary atresia, where you are not getting the normal amount of antegrade or forward flow across the pulmonary valve, we will see ductus arteriosus blood flow the opposite direction. So the aortic outflow, or that V, the transverse arch, is going towards the descending aorta, but then the ductal arch is going back towards the pulmonary artery in the opposite direction to help supply blood that we are not getting enough antegrade. Like if they're in opposite directions, that's a red flag.
Right.
They should be going the same direction.
Right. Gosh, there's just so much that goes into a fetal echo. It just blows my mind. But when you confirm a cardiac abnormality, how do you approach explaining that to expecting parents? They've been referred there and you do the fetal echo. Then, how do you explain that to them when you confirm abnormalities?
Yeah, so this is a really important part of the job. There's one part is obviously being knowledgeable and skilled enough to make the diagnosis. And really, it's a team effort where the sonographer who's doing the bulk of the imaging really is an important part of setting the stage for my counseling, because just the environment and our interactions with the patient starting from the very beginning really play a role in their experience. That can be very stressful, especially if they're referred for a concern for a heart defect. And so really, as a team, approaching these patients with a lot of respect and really, quote, reading the room where they are. So if we do confirm a heart defect, I will say and back up, if a patient gets referred to us because a sonographer or provider is concerned that they couldn't get the right 3-vessel view, or there is the discrepant size of chambers or something, it's kind of vague, but they know something's not right. And I think that is one takeaway, that you don't need to know what the diagnosis is. Just if something is not right, that is enough to refer. But I like to meet the family, the patient, even before we start the scan, to sort of go over the history and everything, introductions in the history. It's harder to just walk in, the sonographer's done the images, and then you walk in to talk about it when, they know something may be abnormal, and then to also then cover their medications and their past medical history. So first, right, I like to get that out of the way first and explain to them that we could take 30, 40 minutes, maybe depending on baby's position and, quality of imaging, et cetera, movement, that it may take a while to get through a thorough exam, but that we will take as long as we need to afterwards to discuss the results. So I start by trying to do an introduction first, and then we do the scan. And if we do confirm an abnormality, our team will make a heart diagram, because I think heart defects is a very visual thing, and it's something that the family can take with them as well. And so when we go to do the counseling, I usually start by saying that we do confirm that there is a heart defect, or a concern about the heart. And I usually try, because I know once I say those words, that the patient and family may really not remember a lot of what else I'm going to say. They're not going to remember potentially all the details of the anatomy that my sonographer and I have spent all this time trying to tease out. What they want to know is, number one, is there a heart defect? And so once I confirm that, I say, number two, where will they need to deliver? Because in St. Louis, we get a lot of referrals from out of town. And so can they deliver? And all the critical heart defects should deliver at a tertiary center where there is pediatric cardiac services available. If their baby is going to need intervention soon after birth or eventual surgery, and then always, if this is true, I expect a really good outcome. And I really just sort of say that up front, that these are the main points that I want them to remember. Yes, there is a heart defect. We would recommend that you have a delivery plan that includes being at a pediatric cardiac center. Your baby will need an intervention that is applicable in the neonatal period or maybe later, but that I expect a good outcome. And I hope most of the things these days I can say that, and then go into the details of the anatomy.
So it definitely changes the delivery plan, and they have to deliver it where pediatric cardiology is, so in a larger hospital. What do you wish every sonographer understood before we refer for a fetal echo? Is there one thing, or
Yeah, I think just the continued practice of those views that we talked about. But I think, and I've already mentioned this earlier, I think one thing that I always wish referring providers and practices would know is to send the patient to us rather than later if you suspect a problem. So we will get referrals where we see that they couldn't get the right views or unsure, come back in 2 or 4 weeks. And so we would rather get them before that, as soon as you suspect a problem, in order that we can give the family information as soon as possible that may influence their decision about their pregnancy. And so, and then we also take away the waiting, the stress, and that when you call us, Lynn, if you were to call me and say, I have a suspected abnormality, we will get your patient in. We will offer an appointment within 24, if not, or at least 48 hours. We take this as kind of our version of a quote medical emergency in the fetal cardiology world. It's true, we're nothing that we can intervene upon per se most of the time, but for the family's peace of mind, or to understand, we just don't want them to wait. So we consider it urgent. If you suspect a problem, we will get them in to see. And so I would rather that people send patients to us sooner rather than say, you know what, we'll take another look because maybe the baby's position was off. If you have a hunch or some feeling that something's wrong, just refer.
so straight to fetal echo, not necessarily through maternal fetal medicine and then to fetal echo? Because it seems like a lot of times that's kind of how it goes. And I think the confirmation part comes in where, like, what if we messed up? What if it's okay? What if, and what if we need to confirm this because our patient doesn't have the resources to travel to St. Louis for a fetal echo. And so we want to check again. We want to confirm it before we have her go through all that added expense or, assistance with travel needs.
Yeah, I think it's great that you're sort of looking at the whole picture and understanding your patient's limitations or needs. And I think sort of working it out, sometimes we'll offer an appointment the next day, but realistically, because of childcare or distance or transportation, they can't get there on time, but at least we've offered it. Now, whether to go through maternal fetal medicine first, I mean, that is something I think every center has and every provider has their own sort of comfort level with the referral pattern or their go-to people. I just know that if you were to call, if anyone calls us on the fetal cardiology side, whether it be the primary OB provider, wherever in our region or an MFM next door to us, we will always offer an appointment quickly.
Right. That's awesome. Any advice for sonographers who want to strengthen their fetal heart scanning skills? Practice, practice, practice.
Practice, practice, practice. And, if you can have a friendly fetal cardiologist or fetal echo sonographer to work with you or give feedback, I think that would be very helpful too. Because really, it's about, sometimes you don't know what you don't know. Like, you could be getting the images, but not really recognizing what golden information you have there. So to have those relationships or call upon those people that you may be referring to. So we try and give feedback as the fetal echo team to the local OBs to, gosh, your sonographer, what an amazing pickup. I saw that this is what they suspected was wrong and they were spot on, and so to have that conversation about that directly with the providers. But these days there are so many resources as well. Online, I mean, what a plethora of information. And there are really good guidelines from professional organizations. One of them is from the American Society of Echocardiography. So that's coming from my sort of organization that I'm familiar with from the cardiology standpoint. ACE, American Society of Echocardiography, has a document from 2023 called Guidelines and Recommendations for the Performance of the Fetal Echo. And so that has nice pictures and imaging and some tips and reviews, sort of the indications for a fetal echo, and even some management options as well. Then there's the AIUM practice parameters for the performance of a fetal echocardiogram. And I think people in ultrasound who do lots of ultrasound modalities are familiar with that organization. So coming either from the cardiology side or the ultrasound side, there are really good guidelines with good illustrations. And then one textbook that I really liked, that I recommend to all of our fellows in training who are just starting out on fetal echo, is by Julia Dross, who is a sonographer. And she wrote this small book called Fetal Echocardiography. And when I was learning fetal echo and the views and how to think about scanning, I found her book really, really practical. So I really liked that as well.
I will have to get that for sure.
And then there's the Fetal Heart Society that has some educational videos or webinars that are posted as well. So yeah, just lots of things online.
Now, do you think it's true that if you know the normal views, if you know what normal looks like, if you know that's supposed to be a V shape, if you know the left outflow tract is supposed to have that continuous, continuity, if you know the normal views, that you will more than likely pick up those abnormal findings, like you said, even if you don't know what they are, make the referral.
Right. I think that's really, I don't think you have to worry so much about what's abnormal, but yes, just really knowing that
something is abnormal.
And that's where those resources that I mentioned have good illustrations or sort of photos, pictures of what normal should look like. And so then you can incorporate that as you're scanning. And then if something's off from that, yes, you can refer.
Great. Thank you so much for joining me today. I think we covered a lot and all those heart views, and thank you so much for going through all that with us in so much detail. Any final thoughts for our listeners about the importance of fetal echo in prenatal care?
My final thought is that sonographers are where it's at. I mean, as a cardiologist and someone who focuses on echo, transthoracic, transesophageal, and fetal echo, I know that the care I can give and the interpretation is really only as good as my sonographer. So to really learn those skills, I think you can have such an impact on the trajectory of a patient's journey through their pregnancy and for the safe delivery of a baby with a possible heart defect. So I just say hats off to the sonographers. I love what you're doing to teach and to really help people learn. And it really is an ongoing learning experience. 20 years in as a pediatric cardiologist, every day, it's like you never know what you're going to see. And I'm hoping to get better and better every day, but there will be some misses as well, especially those darn perimembranous VSDs, but to keep going. And I think, such an impact you can make on a pregnancy planning and on a child's outcome.
Yeah, make a real difference in the, neonatal mortality and morbidity and how things go from there. As we wrap up today's episode, I want to thank Dr. Caroline Lee for sharing her expertise and her heart with us. No pun intended. Fetal echocardiography gives us an incredible window into early cardiac development, and understanding these views and flow patterns helps us make more accurate assessments earlier in pregnancy. Whether you're scanning as a student or you've been in ultrasound for years, take time to really learn the fetal heart. From the 4-chamber view to the outflow tracts and color flow dynamics makes all the difference in patient care and outcomes. If you enjoyed this episode, please be sure to check out the Sono Techniques Academy app for voice-guided fetal heart lessons and AIUM-based scan checklists. And remember, each image we capture tells a story that can change a life. Thank you so much for joining me for this episode of the Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to the Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sono Techniques Academy. Explore more educational resources on the Sono Techniques Academy app, or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.